Hi there, and welcome back to Sparks, a spotlight series from the Boost community. Today we are honored to welcome Lynka, Rita, and John, a stellar team representing the EPI Leadership and Management Program, also known as EPI LAMP. Today we will be diving into this team's breakthrough project, which is at the heart of each EPI LAMP program team. For this breakthrough project, Team Uganda used a comparison district to analyze how to improve measles-rubella coverage in Bukomansimbi, one of the lowest covered districts in Uganda. Continue listening to learn more about the EPI LAMP program and hear from the Ugandan team on how they collected data and conducted interviews amidst COVID-19 to inform their breakthrough project, as well as tap into some of their key lessons learned. Here's Lynka to get us started.
My name is Lynka. I'm a program manager of the Yale Global Health Leadership Initiative. I manage the daily operations of EPI LAMP. Particularly, I was a learning coach, making sure that teams successfully complete the program and all activities within the program. EPI LAMP is the EPI Leadership and Management Program, which is a 9-month certificate program commissioned by Gavi, the Vaccine Alliance, and offered by Yale Global Health Leadership Initiative in collaboration with the University of Global Health Equity in Rwanda, with PAF, with the University of Yaoundé and the Ministry of Health in Cameroon. The program engages national immunization teams within ministries of health in Gavi-eligible countries. Participants in the program come together as a team to build their management and leadership capacity in strategic problem solving, leadership, leading effective teams, political engagement, human resource management, financial management, and supply chain management. Since 2018, EPI LAMP has been successfully delivered to 5 cohorts, and we have reached 100 alumni across 27 country teams from Anglophone and Francophone Africa and Asia. EPI LAMP is an experiential blended learning program for senior professionals, and it includes e-learning, assignments, and live sessions. Previously, the program included in-person forums, but with COVID-19, we had to adapt the program to a fully virtual model. At the heart of EPI LAMP, there is the Breakthrough Project. The Breakthrough Project is a field project that is defined and implemented by each country team, and delegations receive coaching on the Breakthrough Project from management and technical coaches. At the end of the program, successful participants receive a certificate of completion from all partner institutions. Now, I'd like to introduce you to the EPI LAMP Ugandan team as they will be presenting their Breakthrough Project.
I'm Rita Atugonza. I'm a senior medical officer in the expanded program of immunization, Uganda. I was one of 6 members of Team Uganda for the EPI LAMP 2020 class. My colleagues included Dr. Immaculate Ampere, senior medical officer in the program, Dr. Rachel Bayagida, senior medical officer in the program, Mr. John Kisa, the data manager, and will also introduce himself further, Dr. Fred Nsubuga, another senior medical officer, and Mr. Fred Ngania, who is the monitoring and evaluation specialist in the program.
As Rita said, Kisa John, I'm a data manager in the program, and I support areas related to data analysis and monitoring and evaluation.
As part of the EPI LAMP course, we had to come up with a project that would eventually have an impact, not just for one particular antigen, but across the different scope of activities that we do. After reviewing quite a number of problems that we were facing, we zeroed in on the issue of the measles-rubella vaccine. As a country, the goal is a 95% coverage, as recommended by the African Region Measles-Rubella Elimination Strategy and in our strategic plan for measles-rubella elimination as a country. For Uganda, when we looked at our performance as of October 2020, our coverage for measles-rubella was 85%. We only had about 28 districts that had actually attained the target of 95% coverage, but the bulk of our districts were still below this target, and 12 districts had coverage of less than 70%. Of these 12 districts, Bukomansimbi district had been performing at less than 60% over the last 5 years.
When we discovered Bukomansimbi as a district with persistently low coverage, we attempted to look at the root cause analysis, which helped us to deep dive to know the underlying challenges that could be contributing to low coverage. We looked at the environment where, after discussion with the district health team members, they shared with us some of the areas which were hard to reach, and therefore the services were not readily available to the population. We also looked at the component of people, and some of the issues which came up were related to the poor attitude of the district health teams towards work and accountability. Under the policy and processes, some of the issues which emerged were related to lack of focused supervision for EPI services, lack of supervision plan, minimum follow-up, limited performance reviews. There was also irregular district health management team meetings. And equipment, we were looking at issues related to the cold chain. The issues which came up were related to limited transport to coordinate health facility activities, the breakdown of cold chain and equipment at the district.
After we identified Bukomansimbi as a low-performing district, we set out an objective to increase the measles-rubella coverage in Bukomansimbi district by 10% by March of 2022. We then looked at how we could verify the data that we had, and then how we could also go ahead to collect information, not just from Bukomansimbi, but later on a comparison district. The methods that we used for data collection, we did document reviews using supervision reports from that region and the project reports that were shared by implementing partners. We also had in-depth interviews with the Bukomansimbi district health team. We met about 15 members of the district health team in 2 virtual meetings. We also interviewed one of the program officers in the ministry who is in charge of coordinating that region and Bukomansimbi district. After reviews and the interviews, we formulated the root cause analysis that John has described, and then thought to go ahead and identify a district that had similar attributes to Bukomansimbi, but was performing well and had a good coverage. Then try to find out what the differences were. Why, despite the similarities, one was performing better than the other.
Just as Dr. Rita has highlighted, we attempted to get a district with similar characteristics so that we can compare and find out the underlying root cause of low coverage for Bukomansimbi district. We noticed Gomba district having very similar characteristics in terms of geographical location, as we can see on the map, and also in terms of population size. The other factors which were common were the partners who were supporting the region. So with that, we were able to identify and come up with Gomba district for us to be able to get the underlying root cause for low coverage. Following the deep dive between Bukomansimbi district and Gomba, we performed devious analysis and showed that the average over the past 5 years for MR for Bukomansimbi was 57%, whereas Gomba had 77%. When we look at the aspect of leadership and governance, we noticed that there was urgent need to strengthen coordination of health resources for API service delivery, whereas for Gomba, there was a proactive DHO and DHT supported by health assistants at parish and village level. Looking at human resources for health, Bukomansimbi had 80% of approved staff positions which were filled, whereas Gomba district had 90% of approved staff positions. Looking at the aspect of health information systems, we noticed that Bukomansimbi, they have healthcare workers who are not well versed with management information tools, whereas Gomba district had a proactive biostatistician and a team who support healthcare workers to ensure that there's complete and timely reports submitted. Looking at the aspect of financing, Bukomansimbi, we noticed that there was inadequate funds to support outreaches and other related EPI services, whereas Gomba district, they were effectively using resources from different sources like primary healthcare funds, the Gavi, and implementing partners.
The root cause analysis that we had with Gomba, the comparison district, revealed that low vaccination coverage that we had seen over the past 5 years with Bukomansimbi was due to inadequate coordination of EPI service delivery at the district level. We came up with 3 potential solutions to address this issue. The first was to train the district health management teams in leadership and management. The second option was to encourage consensus building, feedback at regular district and facility level meetings. And the third was to involve political and administrative leadership in focused supportive supervision to optimize the resources they had available. The team, in consensus with the district health team, reviewed these 3 options, and the biggest impact would be to encourage consensus building and also feedback at regular district and facility level meetings to improve coordination in the district.
Following the observations, we had a list of next steps as part of strengthening Bukomansimbi district in improving their coverages. One of them were to hold entry meetings with the district and health facility leadership. We also plan to develop and update a district health team WhatsApp group to allow for follow-up and timely action, hold monthly district coordination meetings, sending reminders for meetings, and develop a standard agenda for the district health team meetings. We also plan to orient the district biostatistician on data analysis for action, develop action matrix, conduct midterm review of the activities which have been instituted, and finally hold a close-up review meeting and hand over to the district leadership.
I think the project that the team chose is one that can actually be replicated for quite a number of challenges that we face as a program. In this particular project, we were looking at coverage of an antigen that's very important to us, and of course, globally, the measles-rubella antigen. But in focusing on a district and trying to study the problems they were facing, and then looking at another district that was performing well, we were able to study the health system in that particular region. And we realized how important leadership and coordination is at all levels, at national, at regional, and at district level. A lot of the issues we face as a program, as a country, even with limited resources, if you have a well-led and coordinated team, you can come up with solutions that you can then apply in your setting and actually see improvement. I think the comparison district was very key in illustrating that fact, because we got 2 districts that were similar sizes, the same region, the same resources, but very different coverage performances. So it illustrated good leadership as very key when it comes to performance.